Hi everyone, thank you for joining. We're just waiting for a few more people to be admitted to the meeting and we'll get started in a second. Conscious of the time, I think there's still people being admitted into the meeting, but I think we should make a start. So thank you very much everyone for joining. Good morning, good afternoon, or good evening, depending on where you are around the world. I hope for your sake the weather is much better than it is in London, where it is grey and raining and very, very windy. Um, but a couple of housekeeping rules before we get started. This meeting will be conducted in English, but there is interpretation in French, as you can see on your screens. Please see the instructions on screen in terms of how to access the French interpretation. Apologies that I'm not able to say this in French. I hope that the translators or that you can read the kind of notes in French. Um, just a second point, which is where this is being conducted as a meeting and kind of not as a webinar, so you are able to come off mute, but we prefer, well, please can you not come off mute until the kind of discussion Q&A part later in the agenda. So I think we should get started. So I'm Hitam Patel. I'm the head of strategy in the Green NHS team in NHS England, and we are kind of part of the team that is driving the kind of National Health Service in England's kind of journey towards decarbonising the health service by 2045. Today, we'll be presenting on behalf of the ATACH Task Team for measuring greenhouse gas emissions in health systems, co-led by the World Health Organization, the Centre for Sustainable Medicine at the National University of Singapore, and of course us, the Green NHS, from part of NHS England. I hope that many of you have seen that we published guidance at COP30 in Belém, setting out a kind of common approach for health system emissions measurement that is aligned with kind of international standards and kind of best practice. It also kind of set out how health systems can develop the kind of necessary internal capabilities to measure their emissions consistently and effectively over time. Um, and we'll hear a bit more about that today. We're going to start with some opening remarks from the WHO, the NHS, and the Centre for Sustainable Medicine. And then we'll hear from the excellent Tom Andrew, who will talk you through the kind of guidance in and of itself. And then we'll get a kind of feeling from different countries across the globe, or health systems, I should say, who will tell you a little bit about how they are aligning or aligned with the guidance and what they have done already to kind of measure their greenhouse gas emissions. We'll be hearing from Australia, the Philippines, and the NHS in England. And then finally, and I hope by this point, for those of you that have already got kind of decarbonisation kind of trajectories and health system greenhouse gas assessments and baselines, you'll kind of know where you want to or think about where you might want to improve over the coming years. And for those of you that where this is still on your to-do list, I hope you'll be inspired kind of to take action over the coming months. And if not, you'll have an opportunity to kind of ask questions with it through a facilitated discussion, and then we'll hear some closing remarks. But I'm very conscious of the kind of time, and there's a lot to get through today. So I will stop sharing my screen and I'll go to Dermot Campbell Landrum, who is the head of climate change, energy, and air quality unit at the WHO, for some opening remarks. Thank you.
Thanks so much, Hitan. It's an absolute pleasure to join you. actually from elsewhere in London, but equally wet and windy. And first off, I'd just like to really pay thanks to our partners in this exercise, NHS England and National University of Singapore, who've been really excellent partners in all of this work and bringing their huge technical leadership to bear on this issue. I think everybody who is joining this meeting knows why we're here, and that's because health systems or the healthcare supply chain is a significant contributor to overall greenhouse gas emissions. You'll, I think, know the approximate figures of something like 5% of global greenhouse gas emissions are attributable to healthcare, including the supply chain. And that's not surprising given that healthcare is about 10% of the global economy. So it is really important that we play our part in taking on this global challenge of not emitting any more carbon than we need to in order to provide really excellent health services. In order to do that, of course, we need to know how much carbon is being emitted from the health system and also where it comes from. So we can start to look at the opportunities to level it off or reduce it, because that's really what this exercise is all about. But I think one really important additional consideration is that this does not exist in isolation, this goal of leveling off and reducing carbon emissions. It's all part of the future of healthcare. And I think we're starting to see, as countries start to make progress on this journey, that there is a lot of synergy between the drive to reduce carbon emissions with the drive to improve services and reduce costs. Because many of the technologies that are now either coming online or improving, for example, in renewable energy, are actually making this the rational thing to do, whether it's within health systems or elsewhere in the economy. So we're very keen to ensure that these things are kept together and kept synergistic. From the WHO point of view, many of you will know that in our current 5-year program of work between all of WHO's member states and the Secretariat, climate change is one of only 6 strategic priorities for the organization and the member states. And one of those is around mitigation within health systems and also within society as a whole. So this is now central to WHO's mission. And we're really privileged, I would say, to work with the partners that we're working with, because they really have got world-leading expertise on this, still to many of us, to everybody, I think, relatively new objective of measuring and leveling off carbon emissions within health systems. So we're able to access the best technical expertise and to get that into technical guidance. But I would also say that particularly from the WHO point of view, we really recognize that different countries are in very different situations. It's a very different situation if you're part of running NHS England, the biggest single health service in the world, compared to a rapidly developing economy or a low-income economy. So we need to have both guidance and approaches which are relevant to all of those contexts. So we have the guidance, but I would also say my final remark is also that's a lot of the purpose of the ATACH. It brings together countries, it brings together these different experiences so that we can learn from each other as quickly as possible, so that we don't just have technical guidance in a document, but we also have a community that can share its experience and share these learnings as countries go forward. Because I've just highlighted the leadership of the organizations which have produced this guidance and are taking forward this area of work, that we see a lot of leadership, we see a lot of real technical excellence from many other countries around the world. And we'll move faster and we'll move better if we do that together. And that's what the ATACH is all about. So I'll hand you back to Hiten and the organisers, and look forward to an excellent discussion. Over to you.
Thank you very much, Dermot. Can't agree more that we have to do this together with everyone if we want to succeed. Thank you very much. I'll now go to Chris Gormley. I was going to go Christopher for a second, but Chris Gormley, Chief Sustainability Officer for the NHS in England.
Thanks, Hiten. Hi, everyone. Look, Diarmaid summed it up beautifully there. So I won't add too much more. If there are a couple of things I would reflect on and emphasize, is that this document really has been pulled together, co-drafted by some real experts. They've been doing this for quite some time. So I think my key reflection is that both the co-drafting, but also the engagement, the level of engagement. I think you only have to look at the acknowledgements page at the start of the guidance just to see how many people have contributed to help try and deliver what Diarmaid was outlining at the end there, that this is something that really can be used by everybody. It really does hit those core and key objectives of this to both ensure or try and ensure some level of common approach, consistency, and hope, and also help health systems develop the capability that they already have or need to develop. So I think they were the key reflections, that this really has been pulled together by people with lots of experience. I also reflect that, and I know speaking to colleagues, I think that if this kind of guidance had existed when the NHS was starting its journey, I think it would have helped us go faster. I mean, this really does cut between some of the challenges that we've already faced and lay out a best approach. So it also gives us something to strive for as well. We know we're not there, and we know we can improve more. So I think it's a fabulous document, and I do hope that everyone on this call can at least read it, if not adopt the common approach, or think about taking this common approach back to their own health system and seeing how it applies. So well done to everybody who pulled it together. Thanks, Hitton.
Thank you very much, Chris. I think I completely agree. And finally, Professor Nick Watson, Director for Centre for Sustainable Medicine, National University of Singapore.
Thanks, friends. Thanks, Hitton, Diarmaid, Christopher. Thanks, Ron, for ditching me. I think we were going to do this call together, but you've clearly found a quieter, better place in a hotel room somewhere than this rubbish conference center. I asked the team, what is it that we're actually going to say at the very start of this? And I got a bit of a glib response. I don't know, Nick, say something provocative. I thought about it. I don't know if I have anything too provocative to say, but well, I noticed Chris just turned his camera off. The work the NHS did back in 2008, at the time when it established its first footprint of a healthcare system, 2008, a long time ago, was good then. It was world leading then. If it had published that kind of study today, frankly, it would have been a bit rubbish. It had to improve, it had to iterate, and it did that, right? It wasn't static. The world has moved forward. We have developed new IO models. We've developed categories that help us delve deeper down into the specifics of our healthcare systems. Hell, we've developed PhD programs and master's programs in sustainable healthcare. The Lancet has just announced it's got a big project looking at the sort of foundational building blocks of the footprints. Every product in healthcare, drugs, scans, scalpels, beds, everything you can see. This space has moved and is moving quickly. And so we should expect more of each other, right? We should expect that 5 years from now, when we come back and say to the NHS or to all of our healthcare systems, hey, have you got better? Have you improved the quality and the resolution of your work? The answer is hell yes, we have. Back in 2008, there was only one healthcare system thinking about this. I did a little bit of a count. I think there are 17 healthcare systems in this region alone. I'm in Bangkok at the moment, in this region alone, that currently have full-fledged teams working on health and climate change inside their health ministries. 17. In Europe, I almost can't think of a country that doesn't have one. That's an enormous advance forward. And so that quality, the work that we're doing is rising. It's a good thing. We shouldn't be scared of the fact that that means that we are gaining the ability to look at each other's assessments and our baselines and our targets and hold each other to account. It feels a little bit uncomfortable, sure, but without that, this space doesn't progress. And I guess for me, that is what some of this work is about. It's about giving us the ability, the common language, to look across healthcare systems and say we're not actually as different as we pretend we are. We're actually pretty similar. And so we can get a good sense of where we all are relative to one another. We can learn from each other. And that might be where I will end. This work has taken about a year. It's been a lot of work, actually, partly because the community's grown. Hey, the idea that you would have 118 people show up for an hour webinar on how to footprint healthcare systems emissions. If you tried to run one of those 5 years ago, I promise you it would have been 2.5 people and a dog. It's been a lot of work over the last year or so, but it's only the beginning. We're actually pretty excited, committed to the idea that the 3 institutions that have sort of started some of this work are going to carry it forward and going to pick up pace. We're already talking about what comes next, what the next iteration of this is. Can we start to talk about targets? Can we start to talk about how we measure progress on an annual basis, guidance on how you run some of those analytics? And so I guess I'd like to make sure the discussion talks a little bit about that as well, right? Not just where are we in 2026, where were we in 2008, but where are we going to be in 2030?
Thank you very much, Nick. I completely agree. And it's a wonderful segue, I think, you have made for me into Tom Andrews to talk a little bit more about the detail of the guidance. So Tom is the head of health systems analysis at the Centre for Sustainable Medicine, and he's going to talk you through the kind of guidance that we published at COP30. Over to you, Tom.
Thank you very much, Chitin. I assume because no one is reacting angrily that you can see my slides and that you can see what I've got
We can.
got to present. Excellent. So I have what I think in the agenda with a 20-minute presentation that we've also got some really interesting and frankly more important guests to hear from than me. So I will try and keep this short and try and get us back on schedule a little bit. But I just wanted to go through the actual contents of the guidance and talk about what's in there and what I see as the most significant parts of that guidance, where it's made a bit of progression in this space, and frankly the things that when I was in that NHS team 5 years ago and just starting to get to grips with this GHG measurement stuff, the stuff that I would have found most useful as an analyst in the NHS at that time. So this is our starting point. As Nick said, not too long ago, the NHS footprint was the only pie chart that we had, and we do now have 5, 10, 15, 20 of these things starting to appear from different health systems around the world. And it's really cool. I really like whenever there's a new document released, I go and seek it out. If it's in French, I, try and get a Google Translate version of a 300-page PDF and go and do it there. Similar in Spanish. There's a bunch of really exciting stuff happening. And I think it's great that I no longer know individually all of the people who might be doing this kind of work. But it does mean that there's risk of inconsistency. It means that there's risk of mistranslation when we're talking about what does net zero mean, what does a health system footprint mean. So what we tried to do in this document is really 3 things. It's to bring a bit of clarity to the world of greenhouse gas measurement. It's a very, very jargon heavy field. The greenhouse gas protocol and some of the ISO standards and everything are not written in languages that are intelligible to your average health system worker, to your average doctor, to your average minister. And why should they know that type of language? I think we've tried to bring some more kind of common sense health related language into how we're talking about this. It's the second aim was to create some guidance on how to start doing greenhouse gas measurement. Day one of an analyst on the job whose full-time position it might be to go and build a GHG inventory of a health system. Well, what are the first things that you would do? What are the first 5 things you should measure? And then after that, what are the next 5, 10 things, 15 things you should measure? And then eventually, how do you turn that into a measurement system that is kind of wholesale and comprehensive and embedded within the structure of regular reporting, as we have started to see from several health systems, the NHS being one of those examples. And really to establish a bit of a shared understanding of what a high quality health system footprint is, so that when I am talking to you and saying my health system footprint is 4.1 million tons of carbon here in Singapore, that's comparable to the 20-something megatons of carbon in the NHS model, for example, or in any other health system assessment in the world. So there are lots of reasons to measure emissions that I won't go into for too long, but I think the fundamental part of this is the measurement is only as important as the action that it allows and enables. I could sit in my dark room in a university measuring health system emissions for the next 20 years, and it would do nothing if there weren't people in the system making changes, making policy changes, doing interventions in clinical settings, taking action in the supply chain to actually bring down those emissions in the real world. And we know that those two things will not operate exactly in sync. So we are currently measuring things that we can't quite know for sure in our measurement models, whether the actions that we are taking are bringing emissions down. We are also doing stuff in the real world where we know there are real, genuine emissions reductions, and our models can't quite catch up with them yet. So there is a natural inconsistency sometimes between the real world and the way that we model emissions. And I think as a community, we need to be comfortable and happy with that inconsistency and try and get them closer and closer together over time as they improve in their quality and in the level of detail that they're providing. So the first thing that we've set out is, well, what is a health system assessment in the first place? And I would really encourage you not to try and get all this information from me in a 15-minute presentation, and please do go and read the document and go and look in detail about what is set out in there in terms of how we think, how the task team, not just the people who are leading this conversation, but also the kind of tens and dozens of people who provided really, really helpful input into this through our feedback mechanisms into what a health system boundary looks like. So basically three things. One is that it should cover the entire health system. The easiest way to do that is to define the health system based on expenditure through something like a national health account. The second is the operational boundary. So what do you include? What activities do you include within the health system? And importantly, that needs to include all greenhouse gases within the Kyoto Protocol, plus the volatile anesthetic agents, desflurane, sevoflurane, and isoflurane, and emissions across all domestic and international supply chains. We know that most of the emissions that healthcare is responsible for exist in those supply chains, and it's therefore important to consider those when you are appraising the emissions of a system. And finally, a base year, so defining a sensible year of assessment, ideally one that's not too far in the past. If that historical data does exist, in some instances, it can be useful to also define a baseline against, for example, a 1990 reference year, which is used in lots of the other UN climate processes. The second thing that we've established is what we're calling a maturity framework, which is setting out step by step across a number of different dimensions, the types of things that you should be doing to improve your GHG modeling over time, starting from the very first thing that you would do in kind of week one, month one, year one of setting out on a journey to improve the way that you're measuring emissions, all the way through to what we're calling stage 4 systemization, which kind of reflects where the frontier of GHG measurement is today in the world, but then also providing a bit of a vision of actually, well, what are the things that we expect the GHG measurement world to go in within healthcare in the future as well? What are the next things that we can go and look at? We're talking about kind of having real-time energy monitoring from every hospital through a centralized API that feeds into a monitoring system, for example, or some massive increases that we might expect to see on the supply side in terms of the data that we have associated with supply chain emissions as well. So lots of exciting kind of future-facing stuff there too. Against that framework, we then set out a number of dimensions which we hope you are able to use to actually take an assessment of where you stand today, and importantly, where those capabilities could be improved in the future. So, for example, you might say, well, actually, yeah, we have fully defined our boundary and it's fully in line with the recommendations in the document, but maybe the model is currently sitting in an Excel file on someone's desktop somewhere, and actually there could be some improvements to the technology that you're leveraging to increase the complexity and data quality and reproducibility of those modeling results over time. Um, there's a lot of detail in the report, which unfortunately I can't cover today, but please do go through and actually look at those different dimensions and start to use that framework as a way of saying, well, okay, this is where we are now. This is areas of relative strength and weakness. And importantly, what's the next thing that I could do to improve my measurement function? Um, and then the final thing to say, I think, is when we talk about GHG measurement, lots of us think about baselines because most of the community in this space has only been doing the first measurement in the last few years. So we talk about establishing a benchmark against which future progress can be made. But greenhouse gas measurement covers all of these different dimensions. It's not just about producing the one pie chart, but actually it's then about producing a trajectory for how you are going to decarbonize over time and evidencing that with good quality greenhouse gas measurement. It's about establishing targets and saying by 2050, 2045, 2040, whatever year it is, that's our target year for net zero. And there are a series of interim targets on the way to that point and evidencing that again with good quality GHG data. And then increasingly important, it's about delivery. So if you are collecting data from the system on greenhouse gas performance that allows you to track and monitor GHG emissions, actually sending that back to the system and letting people know how their data is being used and expressing it to the system in terms of greenhouse gas impacts can be a really, really powerful way of motivating people to go and make changes that reduce emissions in the real world. The final thing I will say, and then I will stop sharing and pass back to Hiten, is at that stage 4, we did think it was important to lay down a bit of a benchmark of saying if you are a high ambition or a high emitting health system, if you are taking the decarbonization commitments that you are making seriously, if you want to back that up with the necessary amount of high quality measurement that is required to confirm that those decarbonization efforts are working, these are the key 10 milestones that you need to get towards for those measurement efforts to be taken credibly. Again, all of these things don't guarantee reductions, they don't guarantee success, but they are the things that you would need to have in place to be able to say with confidence, yes, my process of measuring greenhouse gas emissions is of a standard that is high quality enough to actually support deep decarbonization efforts over the long term. This stuff is achievable. This stuff could be ticked off by lots and lots of health systems in a, I think, relatively rapid period of time, especially if you have, as so many places are, starting to have dedicated staff who are spending their time thinking about greenhouse gas modeling on a day-to-day basis. This stuff, all of which will be useful then. This is the kind of stuff that is then able to feed into policy decisions that gives you the confidence to go and make an intervention in the system, knowing that it's backed up by high quality and public greenhouse gas data. And again, this is produces a bit of a checklist. It is flexible enough, we hope, that it allows for the very different realities that there are in different health systems. I've developed greenhouse gas models for a number of different health systems, and I can say with confidence that each of those models looks very different and uses very different data sets. But throughout, all of these kind of general principles are very, very similar, and all of them are pushing towards having access to greenhouse gas data that is useful, that allows people to make decisions, and ultimately allows emissions to be taken down in the real world. I will pause there. And my final comment, my final request is I've loved being part of this process, and I've loved speaking to a bunch of you about greenhouse gas measurement. And there were so many ideas that were really, really interesting, would be incredibly useful, and were far too detailed to be in the scope of this first piece of guidance measurement. So I would love to continue having a discussion about what else this space needs, what else the analysts in this field need, and the next things that this task team could produce on GHG measurement as we continue to progress the field. Thanks very much.
Thank you very much, Tom. That was excellent overview of the guidance, and completely agree and excited to see what comes next. But now we're going to kind of turn to colleagues in Australia with Madeline Skellen, Director of the National Health and Sustainability and Climate Unit at the Australian Centre for Disease Control, who's going to talk to us a little bit about the work they have been doing to kind of measure the emissions baseline for the Australian health system. So hopefully over to you, Madeline, and I hope you're able to share your screen.
Thank you very much, Hiten, and hello everyone, and thank you for the invitation to speak to you. So my name's Madeline Skellen. I'm the Director of the National Health, Sustainability and Climate Unit within the Australian Centre for Disease Control, and that means that I'm responsible for climate and health policy for the Australian government. Can I just start by really acknowledging the great work that went into development of this report, everyone involved in it, but above all, of course, Tom for his brilliant leadership in pulling it together. I'm here to talk today about our work to produce baseline estimates of Australian health system emissions. I'm going to try and share my screen, so let's see how that goes. Great. Hopefully you can see that. Let's see if I can go full. Is it important that I go full screen, Hiten? I'm going to lose you all if I do.
We can see your screen. If you can, then that'd be great. But if not, don't worry. Oh, we can see it full screen.
Okay. Well, I can't see anyone now as usual. So Hiten, just jump in if anything's going wrong or people want to ask questions. Okay. So this is about estimating health system emissions to support as part of our wider work to decarbonise the health system. So this work's taking place as part of our work to implement Australia's first National Health and Climate Strategy, which was published in 2023, and we're now just starting year 3 of a 5-year implementation period. What is the National Health and Climate Strategy? Well, essentially trying to do 2 things. Firstly, well, it's a whole of government plan. Firstly, for addressing the health and wellbeing impacts of climate change. And secondly, addressing the contribution of the health system to climate change through the generation of greenhouse gas emissions in care delivery. I've got another slide about the strategy. I won't dwell on that. What it comes down to is addressing the health impacts of climate change and addressing the contribution of the health system to climate change. And obviously, we're focused on the second. So, health system emissions baseline. So one of the 49 actions in the National Health and Climate Strategy commits to producing baseline estimates of health system emissions and then periodical estimates thereafter to track progress in decarbonising the health system. We published this report in the first half of, in fulfilment of this action, in the first half of 2025, and it's a report that we're very proud of. And perhaps it's worth taking a step back to note that the scope of our health system decarbonisation efforts, is aligned with the scope of our baseline estimates, which is all scopes as well as patient travel to and from health facilities. Okay. Now, why is this important? Because we see health system emissions baseline estimates as a key input into work that is a top priority for us in 2026, which is to develop a national health system decarbonisation roadmap. Here, I've kind of got a diagram. Of course, this is inspired by the diagram from the English NHS, but this is a kind of an extract from the decarbonisation roadmap for New South Wales Health. New South Wales is one of the 6 states in Australia. And it highlights why we need a baseline so that we can understand the relative contribution of different types of emissions, develop strategies for reducing each of those emissions, whether you conceive them as activity areas or sources, and and also prioritize accordingly based on where the largest contribution to emissions is. So we hope by the end of 2026, fingers crossed, maybe a bit later, to have a kind of figure like this representing our decarbonisation trajectory for the whole of Australia. Okay, so how did we estimate the emissions? This is kind of getting a bit technical, but hopefully that's suitable for the audience. So we used a hybrid method, that is a method that combines activity-based and expenditure-based emission sources. And just let me briefly run through what that looked like, and then I'll provide some broader reflections. So for Scope 1 estimates, our Scope 1 estimates, to simplify greatly, were from activity-based emission sources, above all from the National Inventory by Economic Sector, which is published by our Commonwealth Department of Climate Change as part of their national greenhouse accounts, kind of that are published as part of their their UNFCCC obligations. And those NIBES estimates, National Inventory by Economic Sector, are broken up into 116 input-output industry groups, 3 of which pertain to the health system: healthcare services, residential care and social assistance services, and basically pharmaceutical manufacturing. So we based our activity-based estimates largely on them, with some add-ons for the weird and wonderful emission sources that you all know about. For Scope 2, energy-related emissions, we kind of had to use a fairly unique estimation methodology. Unfortunately, Australia doesn't publish emissions data for energy by economic sector. They do publish it for a subset of large economic entities that are caught by some reporting requirements. So we imputed national Scope 2 emissions for the health system by assuming that the ratio of Scope 1 to Scope 2 emissions is the same for those entities that were caught by those reporting obligations as for the ones that weren't caught by them. Then finally, for Scope 3, we produced consumption-based estimates of emissions using environmentally extended input-output methods that many of you would be familiar with. What does that mean? So it starts with producing what's called a consumption inventory, which basically, instead of mapping emissions to production, to the sources based on production, it maps those emissions to consuming sectors. The way we did that was by using that national inventory by economic sector, and then combining that with the national accounts that explain which of those sectors purchase from which sectors, essentially. And when you combine that with the emissions data by economic sector, you can map those emissions from producing sectors to consuming sectors. What that gives you is all of the emissions on an estimated using expenditure data that the health system is responsible for consuming. So if you combine that with these separately obtained Scope 1 and Scope 2 estimates, you have a double counting problem. So what we did to address that double counting problem is that we took that consumption inventory and then made some subtractions from the consumption inventory to avoid double counting of Scope 1 and Scope 2 emissions. So I'll show you what our activity-based sources were from that national inventory by economic sector. Many of the standard things you might be aware of: stationary fuel consumption, air conditioning, lubricants, and so forth. Data on medical nitrous oxide use was available in that national inventory. So we had to look at where our consumption inventory obtained using expenditure data gave estimates of emissions from these sources, and we assumed that those expenditure-based estimates were of lower quality, subtracted them out, and instead provided the activity-based estimates from the National Inventory by Economic Sector. In addition, we used data from a bunch of other sources, that we obtained ourselves using a brilliant analyst that we contracted with to lead development of this report. And I just probably should acknowledge her name's Rachel Desane, and she was the lead author in this report and did a great job. So those kind of areas that we used additional data sources from were air transport, for patient retrieval and so forth, fluorinated anesthetic gases, which Tom mentioned, purchased energy, I explained that, respiratory inhalers. We all know that's a particular source of emissions that needs to be separately treated. Australia has separate data on emissions associated with waste incineration, including clinical waste as a separate category. So we use that data. And then, of course, patient travel data, which is based on kind of general Australian Bureau of Statistics data about travel to health facilities, and then combining that with emissions factors. Okay, so what are some of the problems? Now, what are some of the problems with the estimates that we produce? Now, first thing to say is that anyone who's kind of done this work knows that estimating emissions is like making a sausage. You don't want to see what goes on inside. It's enough to turn you into a vegetarian, or in this case, a skeptic of any estimate of emissions that you ever look at. Because ultimately, there are always going to be assumptions used in the estimation of emissions for any organization or system. And often it won't be possible to get the exact right estimate, and you're faced with making one of two bad assumptions. And the question is, which assumption is worse, or which assumption is least bad? So to just like kind of lay out some of the biggest and most severe ones that go to the validity of our estimates. We included residential care and social assistance services in our health system emissions estimates, because here in Australia, we consider aged care to be fully part of the health system, and that's where aged care is located. But residential care and social assistance services also include sectors that are completely outside the health system boundary, residential disability care, childcare, and so forth. So they're included in our estimates. And in reverse, there are some parts of the health system that were included within these input-output industry groups that we were constrained to work with that couldn't be disaggregated in a way that enabled us to use them. So we didn't include retail or wholesale pharmacy, medical device manufacturing, health insurance. So that's a significant limitation. And also, we didn't include emissions generated overseas, because import data, import expenditure, is not included in the input-output tables in a disaggregated way in the input-output tables that we use to produce our consumption inventory. So obviously, they're all things that we want to address in future work, along with a bunch of other stuff. So what did we produce? We produced the basic output was a table like this. This breaks down emissions by sources. It's worth also noting that a particularly important creative piece of work in producing these estimates was agreeing a set of scope 3 emissions categories. We did that with reference. So this is, say, under purchase goods and services here, manufactured goods, business services, etc. We did that with reference to ISO 140 something something and the GHG protocol, but ultimately then mapping them to expenditure categories in the national accounts was a creative act, and we're talking with other kind of people working in this space in Australia to try and develop a standardized approach. Basic findings, breaking it down by part of the health system, healthcare. Sorry. Headline figure, 23.5 megatons of emissions the health system produced in Australia in 21-22. That's 5.4% of Australia's emissions, 59% healthcare, 33% aged care, 8% pharmaceutical manufacturing. By scope, 7% scope 1, 20% scope 2, 68% scope 3, 6% patient travel. And those figures are very much in line with the kind of estimates that have been produced by comparable jurisdictions. When you try and aggregate those emission sources up to kind of categories that might inform where you should prioritize your mitigation efforts, you get built environment and related things, 32%, supply chain, 40%, they're the big baddies. And so that, that they're the kind of headline figures that we've used to our kind of Department of Health leadership to highlight where our emissions reduction efforts in the health system should be focused. Next steps, and that's my last slide. So in future work, we do want to solve this problem of disaggregating aged care services emissions from residential disability services and childcare. We want to include pharmacy, medical device manufacturing, private health insurance. We want to combine our work with all of the work so Australia is made up of 8 states and territories. And each of those states and territories collects emissions data for their own health systems that wasn't used at all in our estimates. So we've started kind of a mapping exercise, which is what's shown on this page, to try and understand what they're currently collecting and think about how we can do a roll-up to make better use of that data, because where that data is collected, it will generally be of superior quality to what we have access to. Increase the use of activity data for Scope 3. There's some wider data gaps that relate to Australian national greenhouse accounts that I don't need to talk about. But above all, of course, in terms of our next steps, we need to move from measuring emissions at the organisational whole of system level to measuring the emissions associated with individual products or interventions, so that we can inform kind of, choices that can inform choice of, clinical decision-making, choice of intervention, and including not only from expenditure-based sources, but from methods like process-based life cycle assessment. So hopefully I stuck close to time, but if not, I apologize, and I hope that was useful and not too technical, and thank you very much. I'm happy to take questions.
Thank you very much, Maddie. I really appreciate it. That was very comprehensive. Can I just ask if you could just stop sharing your slides, if that's okay? There'll be an opportunity for everyone to kind of ask questions and facilitate discussion. So hopefully we can do that then. I'm going to keep us moving. Over to kind of Ronald Law, Director for Health and Climate Change Office at the Department of Health in the Philippines, who's also going to talk about what they have been doing to kind of measure the greenhouse gas emissions of the Philippine health system. Nice to see you, Ron. I think I can see your slides. I can see your. So over to you. Thank you.
Thank you, Ethan. Are you able to, can you hear me?
Yeah, we can hear you.
So good day, everyone. I'm from the Philippines, but I'm connecting from Bangkok. So first of all, it's a real pleasure for us to be here to share our experience in the Philippine healthcare system, because you may be wondering why, of course, the Philippine health system is such a busy health system, responding to a lot of climate impacts, and then yeah, we're busy implementing universal health coverage, dealing with improvements around service delivery. But of course, we believe that measuring our carbon footprint is such a critical step to make sure our facilities are not only able to protect public health and the environment. So we're now doing a lot of interventions around climate change. So in the way we look at hospitals, we're also particular about decarbonization. So we're looking at energy, how to make better use of our water resources, and of course, understanding these emissions, we believe should also allow us to to cut costs. We can free up some resources, and eventually, of course, we want to build climate resilience, and hopefully, in our own little way, as a low middle income country, we can also show some leadership in terms of being able to deliver, safe, sustainable care despite the pressing challenges of climate change. But of course, this is made possible through the amazing partnership that we have with ATACH-WHO with NUS. So let me share our experience in the next few slides. As everyone knows, the Philippines is one of the world's most climate exposed countries. And yeah, we've been facing escalating health risks from, it's always about the stronger typhoons, of course, and then temperature increasing. So these things are really giving us a whole range of issues. So in the Philippines, at the policy level, we are advancing our health and climate change roadmap. As you can see here, with a lot of support coming from the WHO. This is also, of course, aligned with our national adaptation plan. So our government has this big plan, and increasingly, there's this recognition that the health sector, of course, with that awareness that we're trying to create, that we're also contributing to the problem. So we're now in the process of integrating health considerations in our NDCs, which is for updating, by the way, and of course, aligned with our commitments in relation to the Paris Agreement and, of course, the WHO framework. So, other than adaptation, we're also prioritizing mitigation actions. Though we don't have bold net zero targets yet, and as you know, we're a low emitting country, but of course, we are considering a lot of decarbonization actions that we can do. So, at some point, yeah, we have been talking about having a decarbonization roadmap as well. So, as I've said, we are looking at this in order to save costs, boost efficiency, and hopefully, of course, ultimately, we also want to improve our health service delivery outcomes when we do this. So this is an important priority in our health system right now. But of course, it's good that we already have been doing a lot of things. So our partner office, so it's not only the office that I lead, the climate change office that does all the work. So our colleagues at the Health Facility Development Bureau, back in 2021, with a lot of support coming from partners, of course, the WHO, even UNICEF, the Asian Development Bank, and other stakeholders, we were able to develop this Green Safe Health Facilities Manual. So it's beautiful because we had here something called the GVA, or the Green Viability Assessment. So when it was developed, it was really conceptualized as a rating tool that can measure how our facilities will comply with important performance standards. So there are 8 performance standards, as you can see here. So this sort of serves as our umbrella program. So we built on this to facilitate our decarbonization and mitigation efforts. So in essence, this GVA assesses standards covering governance, energy and water efficiency, as you can see here, even WASH, healthcare waste management, environmental resilient, even site and material sustainability, and indoor environmental quality. But it's such an amazing thing that we were able to develop this, of course, with WHO and NUS support. We were able to develop our own model. So we call it PHCNAG, so which stands for the Philippine Health System Integrated National Accounting of GHGs. So this national model uses Philippine-specific data and emission factors, so we can accurately measure, of course, our healthcare carbon footprint. So similar to what Australia shared, this uses a hybrid approach. So we use spend and activity-based data as aligned with the WHO guidance and global best practice. Of course, we have to strike the balance between being very comprehensive and being very practical as well. So this is equally important to us when we make our decision making. So we have followed the attached guidance, so we can clearly define the boundaries are very important to define. Starting with of course, the organizational boundary, the operational boundaries, and a base year, which was shared by Tom, a few minutes ago, to try to capture all of the GHG sources. And this happens to include international supply chains. So there's an annex that you can look at that supports the development of a robust hybrid model. So this is good because it can enable us to to show progress through time. And with this is good because this can really help us to meet at least 6 of the 10 high ambition health system criteria upon publication. So this is something that's very important and useful for us. So what are our next priorities? So with this, we got a lot of help on being able to identify priority actions to strengthen our GHG measurement, right? So we've started to improve the effectiveness and quality of our grid viability assessment tool, our GVA data collection. So this is something we're working on. We'd also like to highlight the importance of using data to be able to identify the emission hotspots. So this is the most important thing to us because our decision making can only improve if we're able to use, of course, some science and following some guidance. So this is very helpful. And definitely, we're going to use this to inform our strategy and policy. Unfortunately, at this point, cannot share with you the findings. So we decided to hold on to it and maybe publish it at some point. So you'll be able to see all of it. But for now, we're getting ready to integrate the results of this assessment into our existing systems in terms of knowledge management and even information technology, because we have to slowly embed this into our system. So at first, this was not part of our routine health system function. So this entails a lot of capacities also on our end, but we've been learning a lot from this experience. We want to end coming from our unique context. We'd like to share the following lessons. So all of these are very practical for our purpose. So first, I think I believe for other ministers of health working on climate and health who are interested to to take this important decarbonization pathway, first we need to use local data and emission factors that we have that we collect that are important to us. It's based on our existing policies. End of the day, I think that's the most important thing because it should be suitable to our context. So we need to apply country specific data that reflect local grids, production and supply chain. So we need to be able to see a lot of this. So we have to navigate through this different data sources, and we need to avoid distorted results coming from the generic factor. So there are so many technicalities, but we have to make sure this doesn't happen. And I think speaking as a government representative, it's very important that this kind of process, this kind of output, this journey is something that's really taken on by the government. So ownership is very important. But of course, initially we were not so comfortable, but of course we need to increasingly gain our, level of confidence doing this kind of thing because this is a first for us. But we need to keep this within government, so we need to stay updated, uh, and hopefully, in the long term, hopefully we can build institutional capacity with all of the support that we can get from all of you. And third, the importance of building multidisciplinary teams. Yeah, so in the health system, clinicians, engineers. So we've got to really involve different kinds of people. We should really harness, the clinical expertise, technical know-how, and even economic policy and data expertise. Most of this we still have to build and slowly grow. It's part of our competencies, but we believe this will help us ensure accuracy and real world relevance. And finally, the need to act now, and starting with available data tools like the GVA, which we have developed and improve. And of course, this guidance really means a lot to us because we know that this can allow us to, drive immediate practical emission reduction and resilience actions in our health facility. So, as a final point, I'd like to say that for the Philippines, it's important for us to assess our carbon footprint. Again, to help us identify ways to make our hospitals more responsive, more efficient, and more reliable. We'd like to free up more resources, and hopefully, we'll not be able to have expensive mistakes. So improving service delivery and yeah, eventually in our climate and health priorities, being able to create healthier, safer environments, which is important aside from a lot of things that we're doing to make sure we are climate resilient. So adaptation and mitigation, I believe, are twin goals. It should be our top priority, but we're just happy that the mitigation goals that we have and then this exercise of measuring our emissions are taking us further in our journey. So yeah, I think I can end here. So I'll be happy to answer any questions that you may have, but happy to be here. Thank you so much.
Thank you very much, Ron. Really appreciate it. It was really insightful overview of the work that you've been leading, and it's fantastic. Thank you very much. I'm very conscious of time, so I will move us on quickly so that people do have an opportunity to ask questions. I'll hand over to Robin Simpson, Head of Analytics for Green NHS, as part of NHS England, who's going to talk about the work that the NHS in England has been doing to decarbonise to measure its health system baseline. Robin, over to you.
Thanks, Hitten. Can you hear me all right and see?
We can see your slides and we can hear you all right. Perfect.
Lovely. All right. Well, I'll try and move these through these fairly quickly. Good morning, everyone. My name's Robin, as Hitten just said. We've heard a little bit about the history of footprinting the NHS in England, so I won't go through all of this. Just to highlight that as well as that original, as well as footprinting the NHS since 2008, as Nick mentioned earlier, and the delivering a net zero NHS report that set our net zero targets in 2020. Last year, we published our first 5-year review of progress over that period, which also allowed us to set out the improvements we made in our methodology and update our baseline emissions estimates and really give a review of the progress we've made over the past 5 years. So what I'm going to do just quite briefly is basically go through these key milestones that Tom mentioned earlier and give a sense of where the NHS in England is on those. The infographic here gives it away a little bit. We're broadly pretty firmly in this systemization stage of the maturity framework across pretty much all the areas. And in some areas, we're working towards that sort of stage 5 future optimization as well. Although some of those things, still feel like they're quite a long way away to get to that stage. So, in terms of our boundary, so the vast majority of healthcare in England is funded through the NHS, and our boundary is specific to the NHS. We define it through expenditure so total NHS budget as reported through the NHS England annual report, and included in the footprint are all the Kyoto Protocol GHGs plus volatile anesthetic gases, as you can see in the infographic on the right-hand side there. We are committed to reviewing emissions every 5 years. So we've just done that first review, as I said, that was published towards the end of last year. We have a 1990 baseline. That's the baseline for which our 80% reduction target is set. But we also use 2019-20 as a kind of nearer term comparison year. And in our 5-year progress review, we've updated both of those based on improvements to the data that we've now got and improvements to our understanding of emissions in the NHS. And we have shared a detailed description of our methodology In 2020, a academic paper was published in the Lancet Planetary Health Journal that set out the methodological approach, and we have submitted a paper for publication in that same journal, which looks at our improved methodology and also does a comparison between the two approaches. That's currently going through peer review at the moment, so hopefully that will be published in the Lancet Planetary Health as well, or that is available already as a preprint on the preprint server there. In terms of the modelling approach, I did a quick calculation. It's about 25% of our emissions that are currently based on activity data. There's a bit of grey area about what you count as activity-based estimates there, but it's something around that level, so it's within that 15 to 50% mark. Our modelling is built up now. One of the real big improvements we've made in this new methodology compared to 2020 is that a really significant proportion of the estimates are based on organisation level data. So rather than doing a national estimate that we then try and split up into different organisational contributions, the calculations are done at organisation level and then aggregated up into a national estimate. In terms of next steps, it's just continuing on this journey towards including more and more volume-specific and product-specific data. We think we might target medicines as an area to explore, replacing more of our spend-based estimates with volume and specific emissions footprinting data. And also we want to look towards integrating forecasting and scenario analysis into our main model. We currently have capability to do that kind of forward look, but trying to bring that all together into the one model to allow a better running of different scenarios and assessment of the impact of different interventions over time. In terms of data collection and management, we have regular data collection where we have set up new data collections. We focused on trying to keep burden to a minimum, and as a result of that, we get pretty good response rates in general. We have a dashboard which is available internally to NHS colleagues where we can share data back with organisations. So there's an example page there shown on the right. It's supposed to be zoomed out. I'm not expecting you to be able to read it particularly, but this is showing inhalers data. So we've got sort of key metric information at the top. So these lines are average emissions per inhaler for SABA and non-SABA. We have some really detailed monthly volume and emissions data in the middle, and then organisation-specific data at the bottom. And there are filters on this, so you can filter to a given region or individual organisation. And the model that feeds this dashboard is, sorry, the data that feeds this dashboard is exactly the same data that feeds our model estimates. So we have a single version of the truth there. I'm going to move on. So we've been reporting annual estimates of the NHS carbon footprint emissions since 2022-23. And so that's the more direct emissions associated with NHS healthcare. We report the sort of total full scope emissions, which we call the NHS Carbon Footprint Plus, less regularly, roughly every 2 years. But we've moved into this business as usual process for reporting every year in the annual report and accounts. Milestone 6 is around the reporting the impact of individual interventions. So we're moving towards this. I'd say we do include lots of information on that internally within the Greener NHS dashboard. In terms of what we publish, we tend to include the impact in different areas. So, for example, reductions from inhalers or nitrous oxide waste reduction within our report in the NHS England annual report and accounts, but it's currently not within a sort of formal framework of indicators. We are working towards developing that wider framework that includes, yes, emissions reduction estimates, but also a wider range of carbon and non-carbon indicators that can really give a sense of the progress that's being made. So that's an area that we are looking to improve further, building that sort of formal framework of indicators that can give that wider sense of the progress that's being made. We have analysts within NHS England that are fully responsible for developing and maintaining the model that produces emissions estimates. Our aim is to, wherever we can, do things once centrally and then share information rather than lots of different organisations trying to do their own footprinting exercises. The model is built mostly in SQL, and we have the code under version control on GitHub. NHS England has a business critical models quality assurance process that's used to check that any modeling that's used to inform business critical decisions has the right documentation and quality assurance processes in place. So recently the model was assessed and got a good rating through that process. So we do try and focus on making sure the model is documented and sort of resilient. And as I already mentioned, the dashboard is available to NHS staff to see the data that we've got there. So on data governance, Chris, who spoke earlier, our Chief Sustainability Officer, ultimately responsible for the data and reporting of it. And we have had quite a lot of external input into the methodology. In 2020, an expert panel was convened to assess the methodology that we were using. We convened a panel again last year to review our updated approach. You can see the members of the panel there in the box on the right hand side, and we found that to be really helpful, that external input to make sure that we're using the best possible approach and to make sure the sort of assumptions and data we're using is appropriate. And then, yeah, I already mentioned the academic papers, so the peer review process there as well, giving lots of feedback on our approach and how we are communicating it. The Greener NHS team in NHS England is a dedicated sustainability unit, so responsible for measuring and reporting on emissions. And there's also workforce training available to NHS staff about the Green NHS programme in general. So hopefully that was a good sort of helpful summary of what being in that sort of systemization part of the framework looks like. We have been doing it for a long time, as already been mentioned, so it has taken a long time to get to this point. And as Chris said earlier, perhaps this guidance would have helped us get there more quickly. But getting to this point is a long-term exercise. It's not something that can be done overnight. It requires high ambition and dedicated resources over quite an extended period. I would say that making use of existing data and platforms, using the systems that are already there within the health system, has been really helpful for us and helped reduce additional burden on the system as well. And then, as has already been said several times, I agree with all of the summary points from the other speakers today. The measurement is only useful if we're using it to support action and mitigating actions. From whatever point people are at now, the improvements you make have to be ones that will also help you improve decision making and mitigate emissions as much as we can. So that should always be the sort of guiding focus for improvements that are made to emissions estimates. That's the approach that we've taken and the approach we continue to take moving forward and improving our estimates further. So thanks very much. I'll stop there.
Thank you very much, Robin. We appreciate that. Completely agree about the kind of key messages. I'm conscious of the time and I'm going to get us moving because we give an opportunity for people to ask questions. Elena Villalobos-Prats will the ATACH Secretariat lead will kind of talk us through that. So Elena, over to you.
Thank you, Hiten, and thanks everybody, especially the presenters, for the amazing presentations and very detailed. I think that I would just agree with Mick. I think it's quite impressive to see the work that is being advanced in many countries, different contexts, from many areas, and also to see that the guidance is relevant not only for the authors, but for example, I see that the Philippines has been also supported by ADB, which is great. I think I will start with the questions that we have in the chat, but of course, I would like to hear more also from countries, how much they think this guidance is going to be useful for them in different contexts, again, to be able to measure emissions, what else they will need. Because something that is very important, at least for WHO and the ATACH, is to ensure that the capacity that has been put forward by the NHS, the University of Singapore, basically continues to be used and help us advance this very important area of work. So maybe I will start not in order, but maybe Ingun, I saw that you raised a question. Are you there? And would you like to basically explain about this question?
Yes, I am here.
Yes.
Can you hear me?
Perfect. Yeah, we can hear you.
I actually deleted my question again because I summed up to myself that it was a bit critical in the midst of this very positive delivery to ask a very critical question about what more can this method include. So, but now since you call on me, I will post it anyway. No, it's just that I've listened into several of these task teams lately, and the one on supply chain low emission methods has been really inspiring as well. So this is really progressing well. So I'm just thinking about the PAS 2090 that has been presented. And in the method for supply chain measurement, it seemed to me that they've included some environmental emissions as well. I think they mentioned antimicrobial agents to environment and also some other toxic emissions. So I'm just thinking, how does this align? Is it a potential within the tool here to include also the environmental aspects? So that was my question. Thank you.
Thank you, Ingun. I don't know if Tom or any of the presenters would like to respond to this question.
I can have a go, Elena, and then pass on to anyone else who'd like to comment. I think the fundamental answer is yes. You can measure these other things using similar methods to what we are proposing for greenhouse gas emissions. So you can, in lots of multi-region input-output models, which are the foundation of how we build these system-wide models as well, you can go and look at impacts on. It depends on the model that you're using, but on basically anything that is quantifiable throughout a supply chain. So you could go and look at the emission factors for air pollution within the Gloria multi-region input-output model, or you could look at biodiversity impacts, or you could look at potentially other things like job creation that has come from that sources of spending as well. Some of those factors we trust, and some of them are more uncertain. The one that is the best, frankly, within the MRIO space is the greenhouse gas emissions data, because there is very, very high quality reporting on sectoral sources of those kind of GHG related environmental harms. So it is certainly appropriate for GHG reporting. But there is nothing in this guidance that would preclude you from also considering the other wider environmental impacts of your supply chain as well. This specific paper is very, very focused on GHG emissions, and that's quite deliberate. But we do, of course, recognize that there are those other environmental impacts from healthcare that it's important to consider. The other thing I would say related to that is, certain research questions need certain models, and doing a health system-wide model of GHG emissions is really important because we want to consider the entire impact of the system on the whole. Something like the PAS standards are much more focused on the individual product services side of where the level of which you would do the calculations, and therefore it's a lot easier to go into very, very specific detail on some of those things. So different modeling tools for different research questions is another side of it. But if you told me that in a couple of years' time we would be having a similar conversation about some of those other environmental impacts because we fixed GHG accounting in health systems, I would be delighted. But it's going to be a lot of work to get there. Anyone else want to chime in on that or add anything or offer a counter opinion to that?
Okay, I don't see any other speaker aiming to respond. So I will go with the question by Peter Morgan. Peter, I don't know if you would like to come back to this question. I saw that Tom already answered a little bit, but if you would like to basically raise your question, please go ahead.
No, thanks very much for the opportunity and for the speakers for taking us through the document. It's really, really helpful. I think Tom's done an absolutely outstanding job of answering it in the chat. So I'm not sure if we need to explore it anymore, but I just wanted to come on and say, kind of completely agree with what he's proposed there. You know, you have different potential solutions for different policy or research questions, and then how you bring those together in time, I think will be really interesting. You know, as we get more granular data, that we can get more bottom-up approaches to understanding healthcare, we will start weakening the correlation between these top-down models and the actual emissions. So almost I'm really interested to see when that leap of faith moment comes, when it's better to be less accurate, to be more accurate in the future potentially. But yeah, you know, it's the key thing here of, you know, how does this data drive the action that we want to see, how we decarbonize in healthcare because of the information that we're finding out through all these models. So thanks again, Tom, for the answer in the chat and everyone for presenting today.
Thanks, Peter. I have probably one extra thing to add there, which is that we talk about these two models as if they are two separate worlds and they never ever combine. But actually, we already do have high quality LCA data for lots of the things that healthcare consumes. It's just most of those things happen to be petrol and diesel and electricity and inhalers and anesthetic gases. So actually, it's encouraging to see, I think, from everyone that we heard from today who are doing national models, that they are already effectively building these hybrid models with detailed LCA data for those things where we have evidence. And I know for a fact most of these models are actually built in a modular way where as soon as you have LCA data for another thing, you can actually replace your spend-based modeling with some more detailed product-specific data if and when you get it. So yeah, I think the ability of these things, once you have the comprehensive picture to then drill into the detail, has lots and lots of potential to change in the future in a direction, as you say, as the two things start to converge and give you the same answer.
Thank you, Tom. And I think what you just mentioned is very important, specifically for countries. You don't need to have all the resolution for the data that you need. You can start at a higher level with the data that is available for expenditure. But then as you get more detailed data, then it's possible for sure to go into more granular resolution of your estimations. So again, I would like to hear from countries, even if it is to challenge all of the experts that are here with the basic challenges that you face at country level to go with these assessments. I think we would be really willing to hear from you. I just have one more question in the chat by David Brasfield. I don't know if you would like to raise it again, although I see that Tom responded a little bit. But please, countries, we're waiting for your reactions to all of the presentations.
Okay. Do you hear me?
Okay. Yes, we can hear you.
So yeah, my question was just what we have seen is that it's natural to take the low-hanging fruits of mitigations first, and then you have all of these persistent or tenacious mitigations that are still waiting at the end of the reduction curves, which will be much more demanding regarding the investments. So my question is, all of this really wonderful competence and maturization in methodologies that we have seen today that I think Tom has really expressed quite nicely, can these be applied to more advanced economic analysis of the remaining tenacious mitigations that we really need to get to net zero? Thank you.
Thank you, David. Anyone who would like to reflect on David's intervention?
I don't mind saying something briefly on that. I completely recognise that, and it is really challenging. As you say, there are some things that we can do that actually it's relatively straightforward to implement, and you can have big and quick impact, and you can sort of build momentum, and you can be really excited about the short-term reductions that you've achieved, and we've certainly seen quite a few examples of that. But we do know that there are these really difficult problems, and for us, it's very much heat decarbonisation is one of those where it's very difficult to do that. We have a lot of gas boilers in the NHS estate, and it's difficult to sort of remove all of those at the moment. The financial case is in some cases more difficult than in others. So really recognise that that's a challenge. I think being able to measure and understand what is needed is helpful in order to inform longer term strategy around capital investment and where you need to spend money and what impacts you can have. And certainly we have done quite a lot of assessment of what the benefits of investment in the estate are through reduced energy bills and as well as the wider positive impacts, economic impacts of reduced air pollution and lower emissions. So certainly economic modelling is something that we do a lot of to inform our sort of bids for funding into the NHS. And often a lot of the same data that we have that we use for modelling is also informing that analysis and making the case for investment in the health system. So I'm not sure if that completely answers your question, but it's certainly something that we do a lot of, and it sits very much alongside our emissions measurement processes, because it relies on the same kind of data and evidence to make the case for investment in those more difficult decarbonisation actions.
Thank you very much, Robin. My invitation to one last question or intervention or reaction by any of the countries that is connected. I see many countries: Vietnam, Jordan, Lebanon. So please, if you have any hot issue that you would like to share, please feel free to just raise your hands or start speaking. Since I don't see much movement, then I will use my powers as facilitator, basically to hand over my closing to Madeleine, Robin, and Ronald, because I think from the ATACH, something that we see also from WHO, many countries come to us and say, okay, this is very difficult, we don't know how to start, how we are going to do this. And I think they're a little bit overwhelmed by the task ahead of them. Now that you've gone so far in doing this, I would just like to ask you for a recommendation, one sentence, for those countries that have this challenge or plan to assess their emissions, on where to start, or something that will basically build their confidence and capacities and capabilities to do this better, of course, in the future. So over to Madeleine, then Robin, and then Ronald, please.
Thank you. Yeah, so I will just answer based on our own experience for countries that are in a comparable situation. If your country is reporting a national greenhouse inventory under the UNFCCC, then starting with those national greenhouse accounts, or whatever they're called, and looking at what kind of data might be available down to health system level, even if it's very poor quality and contains huge biases, like including childcare, the child emissions from childcare, which is not part of the health system. Starting there, and then looking at what's in the national accounts data, the input-output data. So which sectors of the economy are purchasing goods and services from which sectors? They are the two key starting points that you need to do a basic input-output analysis exercise to produce a consumption inventory. And you can also use that raw emissions data from the greenhouse accounts to produce Scope 1 estimates and then combine them in the manner we described. Now, look, I don't really know how the national accounts and national greenhouse reporting works in countries around the world, but for countries that have those two basic building blocks, I think that that estimate is reproducible, and you've just got to be willing to publish estimates that have clear and obvious terrible errors, like including the childcare sector and the health system, and make assumptions on the basis of which assumption results in the least wrong estimates. Thank you.
I'd agree with that. I think, yeah, don't let perfect be the enemy of good. Also, I think focus on, what decisions that you can see being made around you would you like to inform and to sort of improve from a sustainability point of view, and get data that will help you do that, because that will probably also help you with your modeling approaches as well. So informing decision making, I think, would be a key one.
Ronald, are you still there from PMAC? I think Ronald had to go. So basically, over to you, Hiten, for the closing of this meeting.
Thank you very much, Elena. And sorry to everyone that we've gone slightly over time, but I hope this has been helpful and you're kind of feeling inspired to kind of undertake a greenhouse gas assessment of your health system, or you have kind of seen or identified the opportunities of learning from kind of other health systems that have been here presented today, and kind of can see where you can improve your own assessment. So thank you all for joining. I wanted to say thank you to kind of all of the speakers today for joining. Really very grateful and appreciate it. Lots of people have coming from different times. I think it's nearly time to go to bed in Australia, but I think but anyway, thank you very much to everyone, and I want to say a very quick special thank you to the kind of organizers. I want to say thank you to Lena, Amy, Sammy, Jit, who again should definitely get a big thank you for all of their help. So much appreciated. So thank you. I will leave it there, and hopefully see you soon.